a specially planned and designed webinar on an important day, that is World Lung Day, that is 25th of September 2025. So at the outset, let me thank the headquarters, our leader, our national president, Dr. Dilip, and also our Madam Secretary General, and also the Finance Secretary, the President-elect, and for giving us an opportunity to conduct the webinar. And on our request, they have scheduled this wonderful program in a big way, in accordance and in association and with the support of our JDN Doctors Network. And especially a special mention to our Chairman Dr. Srijit and Indranil, Secretary of the JDN Group. We had a wonderful response. Right now, at this point of time, 473 people are online. So there is a wonderful response, and for the thanks for the motivation from all the headquarters, from our chairman, from all our members, from the JDN Group. So that is the first point I wanted to share. Second one, this is the invitation we have prepared on this occasion, and with the World Lung Day, 25th of September, and the theme of the year is healthy lungs and healthy lives. All of you know, lungs are very important organ in the body, which are very, very essential for the life of the person. It should be male or female or young or old or whatever it is. So we need to take care of our lung health, and we need to take care of all the possible infections to be not to be there. And we need to take all the necessary precautions to prevent lung infections and other comorbidities, along with other things. And especially for any other disease, even metabolic errors and other any long-term infections and other morbidities also, they have an effect on lungs. So that's why the lung health is very, very important. Today we have two eminent speakers, Dr. Upasana from our National Institute of Delhi, and Dr. B.K. Arora from the TBS session of India. These two people are very experienced people. They have a good command on the subject, and they are very much involved and being taken care of all the programs that is related to lung health. And so at this point of time, I already told you all the national leaders are here, and especially, and also not to forget our mentor, Dr. Ketan Desai. And a special mention to be made about the involvement of JDN, I already told. Dr. Indranil has a wonderful motivation, and Srijit Kumar under his guidance, so right now it is 500. We have achieved the goal in a very short time, and let us give a clapping to all the people who are behind, especially the JDN group. So with this introduction, so I'll move on. And we have some ground rules because it's a very, very important topic. Be mute in the mode or unless you're asked to speak. So everybody should be in the mute, and whenever you're asked to speak, you can unmute and then type your questions or remarks in the chat box or raise your hand whenever necessary. Do not disturb the speaker in the middle. So thank you in advance for all your cooperation. And this is our team. Our respected chairman, Dr. Arivya Krishnan, co-chair myself, convener, Dr. Shiv Joshi, members, Dr. Farul, Dr. Ashok Rai, Dr. Atul Kumar, Dr. Kajal Banik, Hariharan, Madhusudana, and Sandeep, Sudhir, and Karan, and our young Turks, IMA JDN team, Dr. Srideep, the chairman, Srijit Kumar, young boy, who has wonderfully conducted the NatCon at Trivandrum, and Indranil, our national secretary, dynamic, and who has motivated our target group. So, and we'll go in this order: welcome and opening remarks, and then inaugural address by the chief guest, and brief messages by the national leaders, and then keynote address by our National Institute director, and talk by Dr. Dr. V.K. Arora, and we'll have, if time permits, some interaction and wrap up and vote of thanks. So I'll stop the presentation at this point of time. And now I request our chair, respected Dr. R.V. Ashokan, who is my mentor and guide right from the beginning. Sir, over to you for your opening remarks.
Thank you, Dr. Sharma. Thank you for leading this activity of the IMA NTP, and full credit to you for conceiving and going through the entire rigorous arrangements. I am happy that our national president is here. He has been a source of inspiration for the TB team, and he has given us a very good team for tuberculosis. I am grateful to Dr. Dilip Banshari, national president. Special mention about the JDN. We have always believed the young doctors of the country have a great say than the established physicians like us in shaping what this country will be, especially in eliminating tuberculosis. The Medical Association has been in the front, and when no one was with the Central TB Division, IMA was with Central TB Division. For the past 25 years or so, IMA has been the leading light for the TB movement of the country, connecting the public sector and the private sector. So much so, at least in the states where we began, like Kerala, the TB drugs are not available outside the program. That was the impact of training and sensitizing doctors. At one point of time, it was argued that the medicalization of the TB care and control has contributed to the failure of the early programs. So this led to the belief that the civil society has an importance, which perhaps quite true. It's very important to expand the program. But the pendulum has come a full the other side, in the sense the clinicians, the people who actually touch, treat, counsel, and document, they need to come back into their TB care and control in a very big way. It's nothing sort of a revolution, TB care and control in these 25 years. If somebody can go into how things have shaped, nothing short of revolution. And our own TB elimination program is one of the very best in the whole of the world, a model, full model for you. The coming of active case finding, stigma reduction, counseling, treatment completion and documentation, these are all lot of responsibilities for the professionals. IMA has co-opted JDN in TB activities for long now. And we believe this is the way to go, which is very much evidence in how Dr. Srijit and Dr. Indranil have carried themselves. I am very grateful to the two eminent personalities who have joined us, Dr. Upasana Agarwal, the Director of the National Institute, and Dr. V.K. Arora, Chairman of the TB Association of India. Welcome to you, sir. Over to you, Dr. B.S. Sharma. Go according to the program. Thank you.
Thank you, sir, for your wonderful opening remarks and giving the overall picture of the activity of IMAs regarding TB control. And now may I request our leader, our IMA chief, Dr. Dilip Bansali, to inaugurate the session and give his blessings and remarks. Over to you, sir, Dr. Dilip.
Thank you, Dr. P.S. Sharma. Good evening, friends. Friends from throughout the length and breadth of the country. Our leader, Dr. Ashokan, past president of IMA, Dr. P.S. Sharma, Dr. Sujit Kumar, Dr. Indranil. Today's two speakers, Dr. Arora and Dr. Upasana Agarwal. My young leaders at the JDN, ladies and gentlemen, it's given me a great pleasure and really a privilege to address you all on this webinar, important day of lung and TB control program. JDN, of course, has been doing a wonderful job under the JDN leadership of Dr. Sujit and Kumar. See, we at least have one CME program every week. Probably that shows the interest what JDN people have shown. The importance of this day today signifies that we have to keep our lungs healthy, stop smoking, stop non-infectious diseases, stop pollution. There are many irritants which cause lung problems, and today we are going to hear two eminent speakers about how we can save our lungs. So my best wishes to this program and best wishes to all of you. Thank you.
Thank you, sir. Thank you for your motivating speech, and thank you for inaugurating our, rather very important program, specially designed program, the webinar on World Lung Day. Now, we have with us our President-elect, Dr. Naik. Sir, over to you for your remarks and message. National President-elect, Dr. Naik.
So, sir is not available. He is busy with some other meeting.
Achha, not available. Okay. Then
The
Madam
HSD
is
is not
available.
available also.
Madam is there.
They are in another meeting.
Another meeting. Okay. Even finance secretary also is engaged.
Yeah, he is available. He's right there.
Achha. Now, sir, may I request Piyush Jain, our finance minister, I can say finance minister of IMA, to give his remarks. Over to you, sir, Dr. Piyush.
Thank you, Dr. P.S. Sharma. Good afternoon, everyone. Respected dear Dr. Dilip Bhanushali, our President, IMA National Headquarters, Dr. Ashokan sir, immediate past President and Chairman, IMA and TV program, Dr. Anil Nayak sir, Dr. Sarvai Datta, Dr. Srinath, National Chairman, IMA JDN, Dr. Indranil, IMA National Secretary JDN, Dr. Shiv Joshi, convener IMA and TV program, and the young leaders of IMA JDN. On this World Lung Day, we are reminded that healthy lungs are the foundations of healthy life. As doctors and future doctors, it is our responsibility to protect, preserve, and promote lung health in our communities. The IMA and TB program is already playing a vital role in our nation's fight against tuberculosis under the able chairmanship of Dr. R.V. Ashokan sir, one of the biggest threat to the lung health. Alongside, through IMA MSN, we are nurturing young minds who will carry this mission forward with passion and commitment. As a finance secretary of IMA, I assure you that the association stands firmly committed to supporting initiatives that strengthen public health, create awareness, and empower both doctors and society to eliminate disease like TB and promote overall lung health. On this occasion, let us all pledge to work together to spread awareness, encourage early diagnosis, ensure treatment adherence, and advocate for tobacco-free and pollution-free environment. Healthy lungs means a healthier India. Together, we can make it happen, and we will definitely try. Thank you, everyone, and best wishes for the program.
Thank you, Jain Bhai, for your motivating speech. You are represented in all our other leaders also from the headquarters. And
Thank you.
I'm very thankful to you. Thank you very much. And now it is the turn of Dr. Srijit Kumar. Srijit and Kumar, the young and dynamic leader, heading the JDN group and motivating them, involving them, enrolling them, encouraging them in all ways. Over to you, Dr. Srijit Kumar.
Thank you very much, sir. Respected National President Dilip sir, immediate past President Ashokan sir, and Chairman of the TB Committee and Secretary of the Committee Sharma sir, my colleagues in JDN, Indranil and other friends, and my dear young doctors. No, it's with great pleasure that JDN is associating with the NTB Committee to host this program. It's our commitment both to protect our health and also physical health and also the health of the profession. Now, Junior Doctor Network, as you all know, is the togetherness of young doctors of the country. anyone who is less than 35 years of age can become a member of JDN. And I'm sure that most of you are members, but some of you, if you are not members, kindly Dr. Indraneel will share the portal. Please do join JDN, because we are associating with IMA and all other professional agencies in extending medical education and offering you such wonderful programs. And let me also remind you that this Sunday, we are coming up with a 2.5 hour accredited CME program through the College of General Practitioner conference, which is happening. We'll share the link here. So those of you who would like to register, please do that. So when you are with JDN, we will ensure academic excellence, and also we will ensure that you get an opportunity to fulfill your mandatory CME credit hours. And also, we will facilitate all your presentations. Like just now, we have concluded the National Youth Mission, where our young doctors were offered a poster and research publication presentation session. We will also help you in, publishing your articles. We already have a tie-up with the Journal of Indian Medical Association. So please do join JDN and avail all the benefits. And along with us, let's also work and pledge for ending tuberculosis and also ensuring lung health of the country. So lungs are vital for us, and IMA is vital for the profession. So do join the network, and let's all together fight for our health and also for the nation's health. Thank you very much. Jai Hind, Jai IMA.
Thank you, Bhai, Srijit Bhai, for your motivating speech and giving information regarding JDN and its activities. And we still remember the hospitality given by you to our national conference. Thank you very much. Now, may I request another young and dynamic leader, Secretary of the JDN, Dr. Indraneel Deshmukh. Over to you, Dr. Indraneel.
Thank you so much, Sharma sir. Respected President Dilip sir, IPP Ashokan sir, Treasurer Piyush Jain sir, our Chairman Dr. Srijitan Kumar sir, Yash Sharma sir, and all the senior leaders and my dear friends. On this World Lung Day, we are reminded of a simple truth, that is, a healthy lung means healthy lives. Today, lung health is under the threat more than ever before. With air pollution emerging as one of the leading cause of respiratory diseases, from urban smoke to indoor air pollutants in rural households, our lungs are continuously exposed to harmful environments and leading to different lung conditions. I would like to take this a moment to acknowledge the tireless efforts of our young medical officers working in rural setup. They stand on the front line, often with limited resources, yet continue to provide primary care and early management of lung diseases for our most vulnerable population. Similarly, our PG residents working in medical colleges and hospitals are contributing through their clinical work, research, and awareness programs. But the responsibility does not end here. Our young private practitioners too can play a crucial role by collaborating with the local health authorities in active TB control, TB elimination programs. Their proximity to communities make them partners in spreading awareness and ensuring early intervention. As the Junior Doctors Network, we are committed to supporting these efforts through education, through CMEs, rural initiatives, collaborative programs. So today, let us pledge to promote early screening, smoke-free environments, vaccination, awareness about pollution and healthy habits. Because this is not just about the clinical treatment, it is about the prevention, advocacy, and leadership. As said by our chairman, sir, IMA Junior Doctors is a young wing of Indian Medical Association. We have very simple online membership portal. There are many benefits you can get by becoming a JDN member. So we'll be sharing the membership link in the group, in the chat box, and you can enroll yourself. Before I conclude, I extend my heartfelt thanks to Ashokan sir and the whole NTB initiative team, P.S. Sharma sir, Hariharan sir, Shiv sir, and everyone for giving JDN this platform to contribute the larger mission of lung health and TB elimination. Thank you very much, sir, for the opportunity.
Thank you, Indra Deshmukh, for your inspiring speech. Youngsters like you are role models nowadays, because with your motivation, I'm very happy. In a very short time, morning I saw a number, and in the WhatsApp group, by evening it's 1,000. I say really fantastic. Hats off to your commitment and your involvement. So keep it up. God bless you. Now I will share my screen once again. Now we are going to the main topic. Now it's my pleasure and pride to introduce our keynote speaker, Dr. Upasana Agarwal, Director of the National Institute of TB and Respiratory Diseases, New Delhi. Madam has done his MD and PhD at IIT Delhi. Now she is the director in office at Delhi, and she was did her internal medicine physician specializing in HIV and HIV TB and pharmacovigilance. HIV TB expert for National AIDS Control Program and Minister of Health, the Government of India, and also core member of the National HIV Guidelines Writing Group. So Madam has served as a principal and co-investigator and several research projects on HIV and TB. And she served as principal and co-investigator for several research projects, and she has more than 50 publications to her credit of original work in the field of HIV, TB, and TB IRS. So, Madam, we welcome you, and 1 second.
Thank you, Dr. Sarma, for the very kind introduction. I hope I'm audible.
I'll stop sharing, Madam, and then you can.
Am I audible, sir?
Yes, you are audible.
Thank you so much.
Yeah.
So,
please go ahead, Madam.
Yes, sir. So I'll just share my screen, sir.
Share your screen.
Yeah. So can you see my screen?
Yes. Make it full screen, Madam. I think it's better. Yeah.
Yeah. So, good afternoon, everyone. Respected Dr. V.K. Arora, sir, Dr. Sarma, Dr. Asokan, Dr. Bhanushali, and all senior IMA leaders and the junior wing of IMA. A warm afternoon to all of you. And today, over the next few slides or so, I will be talking about lung health, basically. I know TB is the biggest killer, pulmonary TB is the biggest killer, but because of tuberculosis, we end up forgetting all the other things that we can do for lung health. So I will talk in brief about a lot of other conditions that we should start focusing on, that we should remember about when we talk about lung health. And thank you for inviting me for this very important talk. And it's very humbling to talk in front of 500 senior people from the IMA. I'm honored with this invitation. So to begin the talk, today is World Lung Day, and what the slogan for this year is healthy lungs, healthy life. So what does it mean? It basically means that there is a vital connection between healthy, strong lungs and the overall well-being. By a healthy life, we mean an overall well life that we live with gusto and fervor. It is basically a call to action in which there is a need for individuals, communities, and governments to work together on prevention, early diagnosis, and accessible treatment for lung conditions. We should ensure that everybody has a right to clean air and there is clean air for everyone, and awareness and promotion of lifestyle which maximizes respiratory health. So what is the problem? Why are we talking about a healthy lung? Well, respiratory diseases remain among the leading causes of morbidity and mortality worldwide. In India, if we look at the non-communicable diseases or the non-infectious diseases, we would look at asthma, COPD, and lung cancer. And if we look at the infectious diseases, then of course, tuberculosis is the captain of men of death in India. Influenzas, COVID, and community-acquired pneumonias, which continue to contribute to significant morbidity and even mortality in immunocompromised and elderly. When you add to these the threats of air pollution, smoking, occupational exposures, and long-term consequences of COVID-19, the burden of lung illness is immense. Before I actually jump into the disease which contribute to respiratory or lung illness, I think we should stop for a minute and think about how we can improve lung health by our lifestyle. A healthy lifestyle directly influences lung health by affecting respiratory function and risk of developing pulmonary diseases. A regular physical activity schedule will optimize lung function. How? It will enhance lung capacity, it will increase your airflow, and it will strengthen the respiratory muscles. Lifestyle habits of not smoking will be a very big intervention for preventing lung diseases. Minimizing respiratory insults like exposure to environmental allergens, outdoor and indoor pollution. Basically, indoor pollution means biomass smoke, that is gobar gas, gobar use of uplas for cooking, and passive smoking. That is what we mean when we say indoor pollution. Vaccinations against respiratory infections, at least we should take those vaccinations which are available and which we can. Maintaining healthy weights to prevent obesity related issues like sleep apnea and asthma exacerbations, and good respiratory hygiene habits. These are certain things that we can do or change in our lifestyle and have a good lung health. Now, coming to the first disease, I will talk about them in very brief, one slide or two slides. Asthma is a big burden where, as far as lung health is concerned in our country, nearly 3 million people have it, and there are different studies from different places in India. Some people say that it is 2% of the population, some people say it is 5%, and there are even studies which are reporting 10%. So you see, it's a big burden. Patient presents as shortness of breath, wheezing, and coughing. It can occur at any age, but it is usually diagnosed in childhood. And this is one of the diseases that really impacts the quality of life of a person. It is a chronic disorder. It is an inflammatory airway disease. But yes, it is characterized by reversible airflow obstruction. And there is an element of allergy and bronchial hyperresponsiveness in asthmas. The main factors responsible for asthma in our society today are genetic factors. They are very strong. There is a very strong genetic factor as far as asthma is concerned, and family history of asthma itself, or even other atopic diseases like eczema, can cause asthma in children and adults. Environmental factors like allergens. There are lots and lots of people in India who are allergic to dust, to pet dander, to cockroach dander, to molds, and to even pollens from trees and flowers. Air pollution, like urban air pollution, vehicle emissions, industrial pollutants, they are a major contributor for development of asthma. Occupational exposures to dust, fumes, and chemicals. Early childhood respiratory infections like RSV and rhinovirus, and lifestyle factors like a sedentary lifestyle are the other reasons which can contribute to development of asthma. If you look at the treatment of asthma, it's a step-up approach to the treatment of asthma. I am not going into details, but what I would like to say is that because there is a strong allergic component to asthma, inhaled corticosteroids and LABA, which are long-acting beta agonists, they are the mainstay of treatment of asthma. And now for rescue also, it is said that we should have smart therapy, meaning that the same inhaler that we use for long-term control, like suppose if I take a glutamate inhaler, which is a combination inhaler of ICS and LABA, and I take it in the morning and the evening for long-term control, then if there is a need for a rescue medication, then I should take the same inhaler, an extra dose of the same inhaler. That is what smart therapy means. And use of Montelukast, like we are so much in the habit of writing Monter LC, Monter FX, and actually they really work in long-term control of asthma, and use of biologics or monoclonal antibodies for severe cases. This is a stepped approach to asthma. And then we should also do some trigger avoidance. Like if you are an asthmatic, it is known that pollens, humidity, smoke, cold air, respiratory infections, these are the things that can trigger asthma. So if you're an asthmatic or your patient is an asthmatic, then please advise them that they should try to avoid exposure to these problems. I know 100% avoidance is not possible, but at least some degree of avoidance is possible. Person can wear a PPE, that means a mask, if he's going out in a place that might be full of pollens. For inside air pollution, you can use air purifiers. For humidity, probably something like air cooling or air conditioner, and vaccinations for prevention of those respiratory infections, which can at least be prevented. Another very important thing that we have to do in asthma and actually in COPD also is that we have to teach our patients the proper inhaler technique. We should encourage the use of spacers, and there should be a component to our prescription in which we tell them how to use a inhaler correctly. Otherwise, patients keep on finishing inhaler after inhaler, and they keep on telling that we are not improving, when most of the times actually it is the technique which is faulty and there is no drug delivery to the lungs. Coming to the second most important disease of which affects lung health in our country, there are about 200 million people worldwide living with COPD. You can see the burden of the disease, 200 million people, out of which 30 million of them are in India alone. If you look at it globally, it is the third leading cause of death in the world. And in India also, it is responsible for nearly 10% of the total deaths that take place. Chronic obstructive pulmonary disease is a progressive lung disease which is characterized by long-term airflow obstruction in the lungs and which is not reversible, not fully reversible. So this is the main component which actually differentiates an asthmatic from somebody with a COPD. It is the reversibility which will actually differentiate whether the person, if it is a reversible obstruction, it would be asthma. If it is a not fully reversible obstruction, it would be COPD. And COPD is actually characterized by mucus production, copious mucus production and sputum, and there is progressive dyspnea and a propensity to get respiratory infections. COPD accounts for a substantial proportion of respiratory illness-related hospital admissions and outpatient visits. The risk factors are tobacco smoking, indoor air pollution, as I said, biomass fuel and passive smoking, occupational exposure, and now an entity that we are seeing more and more, which is causing COPD in our population, is post-tubercular lung disease due to the scarring of lungs by tuberculosis. There are two pathological entities when we talk of COPD. One is chronic bronchitis, which is basically the word or the term itself is self-explanatory. There is chronic inflammation of the airways and there is mucus gland hypertrophy leading to a lot of sputum production. And then there is emphysema, in which there are damaged distal airways and alveoli, causing decreased air exchanges and reduced elastic recoil. As you would see from the risk factors, the element of allergy is low in this particular group. And that is how we will remember the treatment also. The mainstay of cornerstone of treatment in cases of COPD would be LAMA plus LAVA. So what is LAMA? LAMA are basically long-acting muscarinic antagonists like tiotropium. So these components, the LAMA components, dry up secretions in patients of COPD, the thick mucus secretions that are coming, alongside a long-acting or a short-acting from beta-2 agonist. That is your formoterol, and you can even use a short-acting one, that is the salbutamol, and that is also in groups like group A, group B, group E. This is a hierarchy of severity, and in this hierarchy of severity, you can bring in with a single bronchodilator, that is a SABA and SAMA, and a group B would be a dual bronchodilator, that is a LAVA, a long-acting beta-2 agonist with a LAMA. Then there would be non-pharmacological measures like smoking cessations, pulmonary rehab, and physical activity. You see, pulmonary rehab is becoming more and more important. Today, talking about on the World Lung Day, we have to understand that every center now needs a pulmonary rehab. And pulmonary rehab is much more than a simple physiotherapist or simply just blowing into a spirometry machine in which you ask the patient to, with the power of your breath, you tell them to raise the balls in a machine. It is much more developed branch now. take vaccinations on time to prevent exacerbation caused by infections. And in severe cases, even long-term oxygen therapy might be required. Now coming to the next most important killer because of lung disease is lung cancer. Annually, there are about 2.2 million cases in the world, out of which about 1.8 million die. If you look at the Indian context, 80,000 people in a year develop lung cancer, out of which 60,000 die. Can you see the burden of mortality? I mean, it's so high, the burden of, but like practically, you would see that practically every case who is being diagnosed with lung cancer is dying. There's very, very less survival, essentially because the diagnosis is late. The 5-year survival in India is only 10% because it is late diagnosed. And even in Western countries where screenings and diagnosis is relatively early and where TB is not there to complicate the picture of chronic respiratory distress, even there the survival is only 20%. It is responsible for about 11% of cancers in males and about 4% of cancers in females. And the contribution of its death due to cancer in India is 8.5%. The basic risk factor again comes down to smoking. Smoking, vaping, or weed smoking, tobacco smoking, and even weed smoking. Occupational exposures like exposure to asbestos, which can cause mesothelioma, which is a cancerous condition, air pollution, and a genetic predisposition for lung cancer. We all now know that there is some kind of genetic predisposition working in cancers also. There are two kinds of cancers, non-small cell cancer, which is 85% of the cases. They are essentially squamous or adeno. In the squamous cell cancer, there are central lesions and it's also seen in non-smokers, while adenocarcinoma is has peripheral lesions. Then coming to small cell cancer, they are less. They are only responsible for 15% of cases, but they are more aggressive, grow rapidly, metastasize early, have central presentation. The tumor itself shows extensive necrosis, and they have a neuroendocrine element, so there would be some hormonal abnormalities also. This talk, the treatment of chemotherapy, the cancer is really beyond the scope of this talk, so I would not really go into it, except to say if detected early, surgery followed by chemotherapy, radiotherapy, and at times targeted therapy. Now, this is a group of diseases, the air pollution related respiratory diseases, which is coming up in a big way. And the main pollutants which are involved in respiratory disease, here I would like to stop and tell you that air pollution can cause other kinds of diseases also. It can cause cardiovascular disease. Like we would think it is air pollution, so it would only cause respiratory diseases. It is not like that. It can cause other cancers and cardiovascular disease also. But as far as respiratory disease is concerned, the main culprits are fine particles, that is particulate matter 2.5 and 10, the ozone, the nitrogen oxide, and sulfur dioxide. What they do, they irritate the airways, cause inflammation, reduce lung function, and even damage the DNA. And what are the diseases that they can cause? Respiratory diseases, asthma, they can trigger it or even worsen it. They can cause chronic bronchitis, which is a part of COPD. It can increase your risk for infections. It can reduce lung development in children. And of course, long-term exposure to PM 2.5 and black carbon can cause lung cancer. The main stage of management would be control of symptoms and reduction of exposure to these pollutants. Coming to occupational lung diseases, very much ignored in our country. Nobody will talk about the plight of people working in these particular industries where they can get occupational lung disease. Pneumoconiosis in the form of silicosis, poll workers pneumoconiosis, asbestosis. Silicosis is due to silica dust seen in stone cutters, construction industries where there is so much of tile cutting. Nobody even tells them what is the personal protective equipment that they can wear. Nobody bothers about these poor workers. Sorry. These poor workers who work in coal mines or with asbestos fibers, what happens to these people? They are very young when they come from their villages. They work in these industries for 10, 15 years. And at the age of 35 or 40, they become respiratory cripples and then go back to their villages and live out a life of respiratory cripple. We don't even talk about them. They are never in the center of any discussion. But this is something that we really have to start thinking about. The other occupational lung diseases, exposure to dust, chemical fumes, and mold. All these traveling salesmen, all these people who are on bikes, all these poor medical representatives who are coming to you sitting on bikes, just look at the amount of exposure they have to chemical fumes and dust, which can cause adult asthma. And when they keep on doing it again and again, it actually worsens any other respiratory problem that they may have. Then, of course, there is bicyanosis, which is the brown lung. It is from cotton, jute, or flax industry. The dust that you can see in the atmosphere in these industry, and it is also an asthma-like problem, which in the long term becomes chronic with irreversibility. And then there would be chronic fumes, which you have during your exposed to chronic fumes in industries like welding, smelting, and industrial chemicals, which can also lead to COPD, bronchitis, and ILD. Their management is essentially avoidance of exposure, symptomatic relief by use of bronchodilators or steroids when it becomes severe, oxygen therapy, even long-term oxygen therapy, and ultimately pulmonary rehabilitation. Now coming to the last one about the last thing that we will discuss now in non-infections would be the long-term sequelae of COVID. Now, this is another thing that has entered the world in the past 4 or 5 years, the long-term sequelae in the form of pulmonary fibrosis or interstitial lung disease, reduced lung function, destructive defects on PFT, pulmonary vascular disease, which can cause persistent dyspnea, reduced exercise tolerance, persistent ground glass opacities on the CT with reticulation, reduced PFT parameters like FEV1, vital capacity, persistent hypoxia on exertion, and a chronic cough. And in rare and severe cases where there is pulmonary vasculature, endothelial injury, it can cause pulmonary hypertension or pulmonary embolism. Though rare, it is very much possible. And before I go on to tuberculosis, the king of all diseases in India, I would like to stop on a slide and talk about smoking. I think this is one of the most modifiable factors that we can modify as far as lung health is concerned. Smoking and its cessation should be in the center of all discussions. It has a profound negative impact on lung health. It is a primary cause of chronic respiratory conditions like COPD and lung cancer, and also increases the susceptibility of a smoker to respiratory infections. Cigarette smoke damages cilia linings, mucociliary clearance is impaired, and toxic chemicals in cigarette smoke. See, along with nicotine, you take in a lot of toxic chemicals when you are smoking. So what do these toxic chemicals do? They cause inflammation and oxidative stress and DNA damage, which can cause alveolar destruction and airway remodeling that is seen in COPD-like conditions. And then the carcinogens in cigarettes and bidis. They can cause direct mutations in the lung tissue and cause lung cancer. So the earlier a person quits, greater are the benefits in overall respiratory health and increased life expectancy. Quitting will slow progression of existing lung disease. It will improve your exercise tolerance and lung function, reduce the risk of lung cancer, and reduce COPD and asthma exacerbations. The main strategy for smoking cessation is nicotine replacement by gums and patches, and some pharmacological agents like varenicline, which are basically tobacco receptor antagonists, and counseling and support group. And now coming to the problem of TB. I know this is an NTB task force. I wanted to talk a little bit about non-TB lung diseases. Because of the burden of TB, these diseases always get pushed to the side. So today I thought it is not World TB Day, it is World Lung Day. So let us talk about some things which are not TB also, but affect the lung health. So coming to TB, India has the highest TB burden in the world with about 25 million people getting active TB annually. Out of these, about 50,000 cases are of HIV TB and 64,000 of drug-resistant TB. And nearly 3 lakh people die of TB in India every year. And out of these TB cases, nearly 60 to 65 cases are pulmonary TB affecting lung health. And despite free TB diagnosis and treatment under NTEP and also the contribution made by our colleagues in the private sector, the burden on individuals and communities is unrelenting. There is a reason for continuing TB cycles. There may be the delays in care, maybe factors like HIV, diabetes, malnutrition, overcrowding, poor living conditions, which keep augmenting the cycle of TB infection from one to the other, drug resistance, which makes many cases untreatable, smoking, alcohol abuse, and a general differential access to healthcare, which keeps the numbers going on and on over the years and decades. Apart from the active TB, TB is also responsible for lung health from the point of view of post-TB lung impairment. TB can cause irreversible lung fibrosis, cavitation, and destruction of lung tissue. This results in impaired gas exchange, reduced lung capacity, and chronic respiratory symptoms like cough, shortness of breath, and hemoptysis, what is commonly and generically known as post-TB lung impairment. Studies have shown that nearly 30 to 40% of TB survivors, that is, you have had active TB, you have taken complete treatment, you are a successful case, you no longer have TB, but there is residual lung impairment in 30 to 40% of TB survivors, and it is more in cases who have extensive initial disease, recurrent disease, or delayed treatment. And the residual impairment not only affects the individual's respiratory health and quality of life, it increases the burden of chronic respiratory disease due to TB multifold on the health service. So now we will talk about revisiting an old enemy. We all know pulmonary TB is treatable. You give 4 drugs, rifampicin, RHZD, commonly called as RHZD, and you give them for the appropriate time, 6 months at least, and probably for 6 months with the possibility of extension, and 12 months in cases of CNS TB and bone TB. We know we have to give them in the correct doses. It has to be as per the weight. If we underdose, the patient will not respond well and will ultimately become drug-resistant TB. But apart from the knowledge that we already have, what today I will discuss in these 3 slides is how the landscape of TB control has evolved rapidly over the past few years and months, and what's new in TB control. If I begin with prevention, now there is a TB preventive treatment available, which goes by the name of 3HP, which is actually 12 doses of rifapentine and INH given weekly to people who are at high risk of developing active TB, like household contacts of TB, diabetics, alcoholics, malnourished people, and geriatric populations. Then there is the concept of active TB screening, which is now, it was always there, but it is now being promoted big time. And all hospitals and services are asked to do community campaigns in slums and other places where we have hotspots by systematically screening everyone with a 4S symptom screen of any cough more than 2 weeks, any weight loss of more than 2 weeks, any night sweats, or any fever more than 2 weeks. If a person responds positive to even one of these symptoms, then the patient is treated as a TB presumptive and investigated for TB. In case TB is ruled out by this 4S symptom screening, by a CY-TB test, and by an X-ray, then this person becomes eligible for the TPT. That means they're high risk, but they don't have active TB. Because for giving TB preventive therapy, the first thing that is required, prerequisite, is that the person should not have active TB. And the ones in systematic screening who turn out to be TB, active TB, they are immediately fast-tracked to treatment and care services. Then the new thing in diagnosis is molecular tests, for which the turnaround time is extremely short. CVNAT and TrueNAT are actually point-of-care tests, which can go right to the peripheral healthcare system, and their turnaround time is basically a few hours. And the beauty of these tests is that not only do they detect MTB, they also diagnose drug resistance within a few hours and at the peripheral level. The other main thing that innovation that has happened in diagnosis now is use of AI technology. We now have AI-based X-ray machines, which we can put in our vans and send to the periphery. And once an X-ray is, a handheld X-ray is taken there with the AI component, and the AI component can tell you which X-ray is abnormal and which patient should be brought back to the hospital, or which patient's sputum should be collected, making our TB screening so much more effective without the need of doctors at every place. What is new in treatment? Well, the diagnosis and treatment of TB has been revolutionized, especially for DRTB, with the new TB drugs, bedaquiline, delamanid, and proteomide. These are 3 new TB drugs being used for drug-resistant TB cases, and these new drugs have come after nearly 60 years of no new TB drug. And the regimens that have been formed using these drugs are so amazing that they have brought down the treatment of DRTB from 24 months to nearly 6 months. The BPAM regimen, the newly launched BPAM regimen, which was launched in the country in late December and January, is now a 6 months all oral DRTB regimen. Then we also have a shorter all oral DRTB regimen, which is only of 9 to 11 months. And then for those cases who have disseminated TB, very severe TB, or who have had drug exposure to second-line TB drugs for more than a month, there is the all oral longer TB regimen, which is longer, but the beauty of this regimen is that it has no injectable. Earlier, the patients used to take 6 months, 9 months of injectables, IM injection, which was so painful and so prohibitive that most of the patients would either stop or they would suffer a lot for the sake of their treatment. The other new intervention is providing nutritional support. It is now recognized globally that good nutritional support will improve TB outcomes, and the government has started 2 policies. One is Nikshay Poshan, in which there is a direct monetary benefit given to all patients diagnosed with TB and registered under Nikshay. And there is a concept of Nikshay Mitra, which is the Prime Minister's Jan Bhagidari program, in which we request people, that is non-governmental people like you and me, other donors, individuals, corporates to adopt TB patients and provide them with a nutritional basket, a month's ration for 6 months in case of drug-sensitive TB, and 18 months or 6 months or whatever may be the actual duration in patients of drug-resistant TB, and the entire course and the entire monetary commitment of one person for a DSTB patient is only 45,000 rupees. So even today from this platform also, I request all of you to become Nikshay Mitra and please adopt a TB patient for 4,500 rupees so that he gets good nutrition for 6 months. And these people are poorest of the poor, and they really need the support of the community from people like you and me and everyone who can make a small difference in somebody's life. And the last new intervention before I go to the newer interventions in the private sector is the digital adherence technologies. See, the program has launched something known as the 99 Dots Lite. Now, what is 99 Dots Lite? It is the use of digital adherence, digital technology for promoting adherence, in which you can give the patient drugs for some time. Like the patient doesn't have to come to you every day to eat the drug. You can give them for some periods like 1 week, 1 month, 2 weeks, and you put the patient in a digital adherence system in which the patient, every time he swallows a pill at home, gives a missed call on that number and his adherence is monitored. His pill taking is registered on that dashboard. Why is it called 99 dots? Because there is a concept that if the patient has taken medicine in his hand, then there is a 99% he will take it, and the missed call on the number on which the missed call is to be given is only revealed to the patient when he punches out the medicine. Then on the flap of the punched out medicine is the phone number on which he is supposed to call and register his missed call. So how does it happen? The patient has suppose a week's drug with him. 1 dose he took in front of the healthcare worker at the dot center. Now he's in the digital adherence technology system. He punches out his daily dose and he gets a hidden number on which he gives a missed call, and therefore his adherence gets monitored digitally and remotely. And finally, the new intervention that we have is involvement of private practitioners. There is increasing recognition that our private colleagues have a vital role to play in TB elimination. And for practitioners, it is said that we should all work together and have uniform TB care policies. So diagnosis, treatment, and recognition of ADR and comorbidity trainings on a uniform platform. notification of all TB cases, whether they are diagnosed in the private sector or in the public sector. And for every TB patient that you register on the Nikshay portal, the private practitioner would also get 500 rupees as a small token of thanks. And your area's district TB officer is supposed to reach out to you and give you the login ID and password for the Nikshay portal. Then once a patient completes your TB treatment, then again the private practitioner would get a rupees 500 small token of thanks, even if that patient was referred out to a government segment. So even if you diagnose a patient of TB and you put it in the Nikshay portal, and then you refer them to, say, a nearby dot center or a private or a government facility, then the day that patient's outcome is declared in the Nikshay, the private practitioner gets a token of thanks. If the private practitioner agrees to be a DOTS provider, then there is a small token of thanks in the way of 2,000 rupees for drug-sensitive TB and 5,000 rupees per patient for drug-resistant TB. And because there was a constant complaint that it is very difficult for the private sector to collaborate with the public sector, now the concept is coming to hire public-private support agencies who are basically liaisons between the private and the public sector. So with this information on new interventions in TB, Dr. Sarma, how much time do I have? Hello? So, okay. So,
Madam, 5 minutes, ma'am.
Okay, so then we should also do vaccinations for lung health, influenza vaccine, pneumococcal vaccine, COVID-19 vaccine for people who have high rates of mortality and morbidity. And just talking about my hospital in 5 minutes, the National Institute of TB and Respiratory Diseases in New Delhi, a tertiary grade research and referral TB hospital. It's a microcosm of India's respiratory illness challenge. We started our work in 1956. We have an OPD which sees nearly 1,400 patients per day, out of which 35% are non-TB respiratory diseases, and the remaining are basically TB cases. We have annually we admit serious TB cases, about 6,500 TB cases. We have an 18-bedded respiratory ICU with 2 beds dedicated for sputum-positive mechanical ventilation, and we have a respiratory emergencies where nearly 250 people attend our services every day. We have a dedicated MDR negative pressure ward, which is 14-bedded. Then we have a private ward for TB patients. We also have sophisticated pulmonary laboratory, a complete bronchoscopy suite with EBUS and video bronchoscopes. We have a complete HIV center in which 14,000 patients visited last year, out of which 113 were HIV TB cases, and we did nearly 9,000 HIV tests last year. Then we have a lung cancer clinic, a tobacco cessation clinic, an allergy clinic, and a sleep clinic. We have a fully functional state-of-art thoracic surgery department, which has recently acquired a robo for robotic surgeries. We have pediatrics ward and pediatrics OPD, and our pediatrics department is a center of excellence for MDR TB treatment in children. We have a high-level microbacteriology lab, which has a biosafety level 3 laboratory. And the quantum of work, as you can see, we do about 70,000 smear microscopies in a year, 16,000 molecular tests, and about 13,000 and 5,000, and nearly 20,000 liquid cultures for MTB in a year. We have a niche laboratory, which is anti-TB drugs, therapeutic drug monitoring laboratory, where we can do drug levels for first line and second line ATT. We have a community outreach area of about 10 lakh, and we have a programmatic management of drug-resistant TB center. And then we have a yoga therapy and research center for our TB patients and respiratory patients. And we are in the process of building a high-level pulmonary rehabilitation, a high-quality pulmonary rehabilitation center. Then we do research at any one time. There are nearly 30 to 40 research protocols going on in our institute. So the key take-home message is promote prevention by smoking cessation, promote prevention of lung disease by smoking cessation, pollution reduction, both indoor and outdoor. Suspect and detect symptoms early, especially in high-risk groups. Look for TB. If no TB in high-risk groups, treat them with TB preventive therapy. Diagnose and refer in a timely manner. Lifestyle advice and health literacy, and collaborate to become partners for lung health with public health initiatives like the TB elimination program and air quality campaigns. And this is my small thanks to you. And I would like to take this opportunity to talk about an international conference in TB and respiratory diseases that we are doing in February 2026. This will be an annual affair, and this is our first conference by the name of NICON 2026, to which I invite all of you to come and share in this academic feast and make it a big success. Thank you so much.
Thank you very much, Upasana Madam, for your wonderful input. You have brought out all the important and relevant points and all the common lung infections and along with the statistics, full data you have given, and also the preventive measures you have rightly highlighted. I mean, you have rightly covered the air pollution and also about the habit of smoking and also and the relation to TB. And also the importance of screening, random screening, and also the newer drugs also you have very much highlighted. And also you have stressed the importance of involvement of the private sector and also about the vaccination. And you have give us a good insight of your institute, the work you are doing. And then we are very thankful to you for the information regarding the annual conference. So, Upasana Madam, thank you very much. Now, let me share my screen to introduce Dr. Arora, our next speaker. So, kindly accept a bouquet, Madam, even though you should have given in the beginning, but it has come in the late for the wonderful presentation, Upasana Madam.
Thank you, sir.
Now,
thank you so much.
So, I think you have to take off your screen. Yeah.
1 second, sir. So now it's my pleasure and pride to introduce Dr. V.K. Arora, Vijay Kumar Arora, as a MBBS, MD, DCD, CTC at Japan, and FNCCP, FIMC, and CAM at FGSI. I got so many fellowships to his credit. Former Vice Chancellor of Santosh University, NCR, Delhi. Director Principal, Santosh University, NCR, Delhi. Director of the LRS Institute. Director Professor of JIPMER, Pondicherry. And additional DGHS of Government of India, Chairman of Delhi Medical Council Disciplinary Committee, President of Indian Justice Society, National College of Statisticians, Indian Geriatric Society and JIPMER, and JIPMER Scientific Society, and President of CIAS, that is Union, and presently is the Chairman of the TB Association of India and also the Patron of Geriatric Society of India, and he is the Executive Director of Indian Journal of Tuberculosis and a Senior Consultant of Respiratory Disease. And also I must just inform all the audience that I have been Dr. Arora is my guru in TB Association right from 2014. That is nearly more than 10 years of experience and other acquaintance, 10 years of guidance from him. And what I am today in the TB Association is because of him and his motivation. And so, sir, kindly accept a bouquet from our side. Now, over to you, sir. I stop screening. Over to you, Dr. Arora.
Thank you very much. I'm not sure if my slides are visible or not, but if my slides are visible, please.
Yes, sir. Very much visible. Yes, sir.
Okay, thank you very much, Professor Sharma, for giving me the opportunity to be amongst you and to talk on the matter that is lung health and the role of professional bodies. I was hearing very attentively to our leaders in Indian Medical Association, especially Professor Bhanushali, who is the president of IMA. And I was greatly impressed by two younger generation people like Dr. Sejit Kumar and Dr. Indrani. I think their words still echo in my mind because it is the younger generation which is coming up, has to take up the whole burden of ensuring that lung health really exists as far as our country is concerned. Why lung health? This is important. And I understand that the target group mainly is the younger generation. Even though Dr. Upasana has really talked practically everything which I am going to talk, including in tuberculosis, because that was not the topic today given to me. But nevertheless, I understand we have a younger generation. Therefore, I will keep my things as easy as possible so that they can resonate with my younger friends. I'm aware there are many senior people are sitting. Professor Ashokan is there, who is the past president. And also Dr. Shiv Josh and others are very, very senior people of IMA. Why lung health? This is very, very important, and it is a critically very important in modern times. Why in modern times this has suddenly become very important? It is because of the new threats that are coming up and a deeper understanding of existing threats which have been already in the country. While respiratory diseases have always existed in the 21st century, environment and lifestyle present unique challenges that make protecting our lungs more crucial than ever. So these two areas, that is the environment change that occurred and the climate change that is occurring, that is affecting globally, and the lifestyle changes, how really they are going to affect our lung health. I think that is an important area which I am going to talk. And secondly, obviously, I will be talking the role of the professional bodies. I'm also a member of the Indian Medical Association, and I have been very intimately involved in the South Delhi branch as well as the central branch of Delhi. And I know that how far and how good we can do as a professional body in the country. In the past, lung health was often associated with smoking only, But today we understand that it is not simple smoking which affects the lungs, but it is a intersectional issues which are tied to environmental policy, urban planning, global health, and personal lifestyle choices like from smoking of cigarettes, bidis, hookahs. We have changed in the cities to vaping, even though it is banned as far as our country is concerned. But globally, vaping is still used as one of the way which helps in cessation of the smoking. Now, protecting lung health is not only our individual concern, but it is a public health imperative, as it requires the community to be good as far lungs are concerned, and their health actually is dependent on the factor that they are saved from the pollution as well as from other infectious diseases which can be prevented. Most of the diseases of respiratory infection, which Dr. Upasana has talked, particularly asthma, COPD, are preventable to a greater extent. Unfortunately, because of the different policies, because of the urban planning, because of the environmental changes, because of the climate changes, is becoming day after day very difficult to control these diseases. Let me show you that what are the reasons, which why lung health is important, and what are the changes that occur in the environment that really affects us to a greater extent. One is air pollution. Dr. Upasana has already talked about air pollution, and which is very, very important part, which leads to not only affect a small population, but large population, rather population of the country. Only yesterday I was saying in Delhi, in spite of now few days we are having rainy season and lot of, air around in the sense that it was windy season, and one expects that the air pollution quality will be good. But unfortunately, in Delhi, still we had 101 AQI. Air quality index was 101, and the normal is less than 50. Now, this is, I'm talking of a day when we expect a good day in Delhi. We are also aware that this pollution AQI index has gone as high as 425 at one time in the year. And you can imagine that the population of Delhi, that matter all over the country, probably gets affected. Climate change affects globally, but environmental change affects local as well as the large population in the local area. And that is why it is very, very important that local areas are taken care of as far as the air pollution is concerned. For example, Delhi is the one where very high, quality of, poor quality of air we find. And of course, it's suburban area also where we find very bad areas. Second is the novel pathogens really have come up. What is this novel pathogen? There are two things are happening, one globalization, and second is happening is the climate change. And both these factors are increasing the novel respiratory pathogen, which spread very, very rapidly. We had seen the pandemic of COVID-19, and we are finding every year after it, the mutational change and making the world practically stand still in COVID. And still we get many times the health alerts because of the mutational viruses that are in the air. The threat of future pandemics from influenza strain or other coronavirus strains remains very, very high. Another point which Dr. Upasana checked was the antimicrobial resistance, The rise of drug-resistant bacteria makes treating once manageable respiratory infections like pneumonia and tuberculosis increasingly difficult. And who is responsible for antimicrobial resistance? We usually say it is we the doctors who write the prescription. It is not the patient who is prescribed the prescription doesn't take it, but it is we, the doctors, who are responsible in creating antimicrobial resistance. There are other factors, but one has to take the blame as such also. We have also to take the blame for its change. Lifestyle factors and climate change are two very important factors, which I will take little later. But the aging global population is another very important factor. We must understand our country was young at one time. Even now we say it is a young country. Young country means with young population. Our country is young. But at this juncture also, if we say that we have almost around 176 million with the geriatric population, which is likely to increase to 194 million. And later, in 2050, it will be almost around 394 million population. So the geriatric population is increasing as far as our country is concerned. And as the population increases, there is a progressive decline in lung functions due to structural changes linked to the reduction in the elasticity of the lung parenchyma as well as weakened muscles. We know that frailty is very common as the people aging occurs. And that's very, very important. However, lifestyle choices are very important if we want the elderly population not to suffer from the lung diseases, and those are not smoking. I think that message must go to the younger generation. Not smoking and staying active are powerful tools, remember, for preserving lung health. Not only you have not to start smoking, but you have also to ensure in the community that this smoking habit goes away. See, natural decline of lung function are known, but that is physiological. But it will not lead to disabling limitation in elderly if the exercise, what Upasana was pointing out, was the rehabilitation, exercising or lung rehabilitations are properly done in these people who may be suffering from asthma or the COPD. Let us see, the next slide is unhealthy teens. That is another thing which is coming up nowadays. Obesity, is a paradox. I'm sure most of you will find it's a paradox in our country where nutrition is a bigger problem. And what we are finding is the obesity also coming up in our country. You will be surprised if I tell you 1 out of every 6 adolescents is now overweight as far as our country is concerned. That is why, Prime Minister, if you hear the news, that the Prime Minister says that let us attack this obesity part, and we must ensure that people understand that obesity doesn't take to your good lung health. It doesn't allow your lung to expand. Young brigade, which is now attending today, I'm sure, must have read the novel of Dixon, where there was a Pickwickian syndrome, where obesity was one of the character of in the novel, and things remain the same. That it leads to not expansion of the lung, and it increases your sleep. Sleep apnea syndrome gets increased. There's a history of snoring, and this is a preventable. That's more important to understand. And who can take up this campaign and create awareness? It is the role of the professional bodies to create awareness. This is the role which has to be played by younger generation to take this message to every home, that one must have not adolescent with overweight. Rather, this is the time that they should pick up the healthy ways to live. Another part is what I was saying, the climate change. Now, this is another important factor, which is really leading to the global warming. We are all aware that climate change creates a vicious circle, Heat and drought lead to more wildfires. More wildfires mean heat-driven ozone enters into the air and makes the air quality very, very bad. It worsens the air quality, and poor air quality triggers asthma attacks, COPD flares up, and increases the hospitalization. If you can reduce this hospitalization by making certain changes in the climate change and over and above the environmental changes that occur, then probably you can play a great role in saving the economy of the country. Otherwise, this climate change and the environmental changes places greater burden on the healthcare system, which themselves are stressed by extreme weather events. They are already stressed, and because of the increased hospitalizations, increased exacerbations of asthma and COPD, the burden not only increases, but economically also, this is not viable. But whose economy is this? It's our country economy, which we have to say. Another part which I was talking about was the aging and smoking. This is another very, very important factor. Are you aware that senior adults, I say the people in the geriatric group, at least 8.5% have still smoke. And if we find the data in the adults, 16.5% of adult population is smoking. In spite of knowing the effects. See, when I was a president of Indian Chess Society, we carried out one of the research, SWORD, SWORD. We tried to find that people are aware, even my IMA members, many of them smoke. My friends smoke. But when you ask them, are you aware about its side effects? Are you aware its toxic effects? Yes, they are quite aware. They know it affects the lung. They know it reduces the capacity of the lung. They know that FE1 gets reduced. They are aware that cardiovascular diseases occur. They are aware that these particles which are having high nickel, high polonium-250, high lead, probably goes in the blood and leads to increase not only lung cancer, but other cancers also of the mouth and other parts of the body also. Cancerous situation becomes more effective. So what I'm trying to say is that smoking is a factor which is preventable. The toxic effect of it is preventable. And what is lacking is still the awareness of it, not only in the community, but also awareness of it in the doctors. I'm not sure how many young people who are attending today are not smoking. Remember, not smoking is the first pledge you should take today to protect your health and protect the healthy life. This is what I want to show you, age-related decline which occurs in men aged 18 to 80 years. You can see that people who are suffering from asthma, but they are non-smokers, if you see the red line above, the decline is there, but decline is not so fast as we find in non-asthmatic smokers. The below line, if you can see, this line you see, is much, those people who are smoker and not asthmatic, their decline is much higher than people who are asthmatic and non-smokers, which means the impact of smoking is more than a disease that is of asthma, more than a disease even that of COPD. Therefore, it is important to understand that how smoking affects your lungs. And once you know there's a decline in the lung elasticity, decline in the vital capacity, decline in the FEV1, then this more leads to respiratory infections, which otherwise might not have occurred. Viruses, bacteria, pneumonias are more likely to occur in these persons. And this is a vicious circle. More infections, more decline of the lung functions. Now, these are the fact sheet. I will like most of you to see this link, note this link, go back. And this is a WHO fact sheet. where WHO, which is a global professional body, along with if you take TB, Stop TB Partnership, along with if you take Union, all these are the professional bodies which give you the guidelines. And what's really affecting the lung at this moment is that these few conditions: asthma and COPD, tuberculosis, acute respiratory infection, pneumonia, influenza, and bronchitis. These are the situations, and I will show you a more interesting slide, that how much burden of these diseases have in the community. More the population, more number of absolute number of people who suffer from the disease, more burden on the country and more economic need, and more pressure on the healthcare system. All this is not only increase of the population, because whenever we talk, we say that burden is more because of the population. But fact remains, this is due to the poor living conditions, the high pollution, and high pollutants in the air, climate change, environment. All these factors join hand together to create worsening of the health, particularly lung health, as far not over our country is concerned, but globally. Even in UK, NHS, now they have restarting respiratory clinics, because earlier they thought all these diseases might not be there, but now again time has come that respiratory clinics are being started. That means the respiratory problems are not only in our country, but globally are present. But yes, the burden of these diseases is very, very high as far our country is concerned. Look at the different burden of diseases which is there. And I want to make you to concentrate on this slide. What is state of lung health and what is critical overview? COPD cases are globally are 65 million. But in my country, India, it is more than around 50%. That means around 48% to be precise. It's 30 million cases are of COPD. Then is the COPD mortality. Globally, it is 3.2 million. And India, it is 1/3 mortality of the COPD is due in India. Lung cancer, of course, in details, she has already talked about it. But similarly, in bronchial asthma prevalence, you see 35 million cases are in India who are suffering from bronchial asthma. So what is really required so that this reduce, the burden of the disease can be reduced, if not burden of the disease, but at least we can give better quality of living to the people who are suffering from the disease. The prevalence and 15% mortality, which is a very, very high number of people who die from bronchial asthma. If we take it, air pollution deaths in India, 1.6 million respiratory diseases deaths occur because of the pollution and affecting the lung. The primary risk factors obviously include tobacco use, air pollution, exposures, occupational hazards, and geriatric predisposition. So, and these are, if you look at, these are preventable diseases. That is why the role of the professional bodies becomes very important. Awareness is one part which I usually feel has to be taken up. But then who is to take up this? Government is busy, I can assure you for that, in treating cases. Preventive part is not there in hand. They are more or less are overwhelmed, and healthcare systems are overburdened with the treatment of the diseases and not taking care as far the prevention part is concerned. So, dear friends, the threats to lung health is because of the tobacco use, environmental factors, and lifestyle changes. In lifestyle changes, one more part I would like to add is the vaping, which is being used in many countries now. Remember, vaping is, or e-cigarette, so-called e-cigarette, are not safe for the lungs. The smoke which comes out of them has high levels of nickel, high levels of lead, and also certain substances which give a flavor like diacetyl, which are in the air and it polluting the air also. So pollution, we know always that it is a burning of the fossils, exhaust of cars, exhaust of trucks, and oil burning, industries exhaust, all these factors we say causes pollution, but we are adding to the pollution. This smoking and vaping are additional, which affects the ozone layer at the earth, leading to many, many respiratory infections. What is this DALY? Now, this is disability adjusted life years is a widely used metrics in public health to quantify the overall burden of the disease in a population. It represents one unit lost year of healthy life due to premature death. And let us see how many DALY occur as far as our country is concerned because of these diseases. Because of the chronic respiratory diseases, global disability adjusted life of DALY years is 32% of the world. 32% of the disability adjusted life years lost in the world, 32% occur in our country. How much we lose the premature death because of the premature deaths and because of the disability of the disease is so high that it's very important that we know exactly how much cost it is. I think this is one parameter which is in the hands of the professional body to project for the excessive funds that are required for these purposes. Out of his COPD, asthma is 75% DALY, which is lost. Mortality is occurring because of this 11% and is rising. Tuberculosis is another, where number of the cases is very less. It's not like 55 million. It's not like so high. It is 2.6 million, but it's a public health problem. That is why the WHO and Stop TB Partnership and other international organizations gave a call. Yes, we can end TB, but for this ending, you have to commit, you have to invest, and you have to deliver. This is the message they are giving. Commitment by whom? Commitment by the professional bodies. Investing by whom? Investing by the government. Delivery, who is going to deliver? It is we are going to deliver, the members of the professional body are going to deliver it. Until unless we join hand with the government and government bodies, it is not easy to control tuberculosis or eliminate tuberculosis. In spite of all efforts and our Prime Minister's help, political will with us, it's not much reduction as such of the incidences. Still, we have around 2.6 million patients who are suffering from tuberculosis. And as Dr. Upasana showed, 64,000 MDR cases have further complicated the situation. and it has become increasingly difficult to treat such cases. The infection is going in the community. It is an infectious disease minded as for tuberculosis. So that is why this has a separate importance as a very, very serious kind of a respiratory disease, along with chronic respiratory diseases like asthma and COPD. These are silent diseases where people are not much worried at this juncture because it is not visible, it is not infectious, it is, but some role of genetics also is there as far as asthma and COPD are concerned. I have always felt that whenever we are controlling any disease, there are two ways to control it. Diagnosing, treating, tracking active cases, and that is what government is doing. But stopping progression from infection to active disease. And it is here where the role of creating awareness and vaccination landscape really comes, which can prevent the infection to progress, and where probably a lot of research is required to be done by the professional bodies. Now I come back to the professional bodies because I have been talking about this, and that's very, very important. Who are the professional bodies? I think this group must be congratulated of Indian Medical Association, who has a lot of members, around 1 lakh plus members and increasing every year because of the increase in the medical colleges. Who are the key players in this? It's not only the IMA members, but it's a multi-sectoral approach has to be there, where not only Indian Medical Association, but they have to join hands with the other associations, particularly the Council of Respiratory Specialists. We know Indian Chest Society is there. We know National College of Chest Physicians is there. We know ICMR is there. We know Council of other respiratory specialists. We are making division. Every specialty is making its own association. But is there any forum which joins hand together? And I think it is only IMA, where practically all specialist groups are part of the IMA. And therefore, there's a greater responsibility on the Indian Medical Association to take up these challenges. Similarly, professional societies are there, like Public Health Society, like TB Association of India. I must, at this juncture, congratulate the Indian Medical Association, which had a memorandum of understanding with the TB Association of India. Because what we are looking at the disease, but we are forgetting the other processes which does not allow the treatment to succeed. And one of the part where we had taken up as a TB Association of India is the action against stigma. I must thank Dr. Bhanushali and Professor Ashokan and other members of the Indian Medical Association. We had written an agreement with them. Just a moment, somebody has come. Let me just open the door. Please don't mind. Just wait for me for a moment. Otherwise, he will go on ringing.
Ranil, can you hear me?
Yes, sir.
See, there is a lot of concern regarding what you have communicated regarding free pass, other things.
Yes,
You
I'm
should
so
make
sorry
a
I had to leave
announcement.
in between for a few minutes. Nevertheless, it's nice talking to you. Probably it gave you a little breath of what I'm talking.
No,
Sir,
no.
just a second,
So
sir.
I was
Vijay,
only
sir.
saying that this is where there are other factors which are not allowing the disease process to be treated, even with the best of the efforts which we are making. And destigmatizing TB, it looks small, but most of you must have experienced while taking part in the action against stigma, that it is playing an important role at this moment for people to come and collect the medicine, people to take the regular medicine, people to ensure that we do not stigmatize the TB patient. You will be surprised to know when we had put this test on the IMA members without naming, 60% of the IMA members were showing that they require counseling to destigmatize the TB. And you can imagine if it is we people are involved in this process, what would have been a situation as the country is concerned. 81% of the population still feel bad as far as the TB is concerned, still stigmatize TB. Not only TB, but you can consider many diseases like HIV. COVID was one time when people were destigmatized. They had a stigma of suffering from COVID. HIV, we all know what happened. See, this is important part to create awareness that this is one very important part which affects our treatment process in the people. What are the forum of international respiratory societies? There are so many, I'm sure IMA is member of all these and they are interacting. I'm quite aware about that. Today, we celebrate on 25th September, the World Lung Day. Globally, it is being debated how lungs can be kept healthy. And there are two guidelines made by the professional bodies for asthma and the COPD. GINA, Global Initiative for Bronchial Asthma, and GOLD. These are the two bodies in the world where the members are WHO members and the NHBL members. They joined hand to give this. But merely giving guidelines doesn't really make any difference. You have to make our own guidelines. I'm aware government makes the guidelines. I'm also aware that IMA members are involved in making the guidelines. And also I am aware that the factual, it is at the end of the day, it is government which runs our health system and not the powerful IMA. We may be taking some time action, but making guidelines and ensuring those guidelines, structured operational guidelines, are followed at every clinic by every member of the Indian Medical Association. This is not happening, and it's a great responsibility because the IMA is such a powerful organization which can not only impact the government agencies but also have an impact on the quality of the care which we are giving to the general public. I am aware about the medical councils in the country. Every state has a medical council. We have also the disciplinary committees to take actions. But nevertheless, probably I think the professional bodies have to do a lot more in making their presence not only with the government, but even its own members by creating guidelines of ethics, guidelines of providing care to the patient and the poor, and also creating guidelines. Now, these are the guidelines which you have to make it, the professional bodies have to make it. Setting standards, code of conduct, promoting ethical practices, collaborating with the government agencies, ensuring quality of care. I think this is a very, very important part. Quality care of the patients which are seen by your members. Quality care in not only creating awareness about the disease process, about preventive part of it, but providing quality care where each one of us brings smiles on the faces of the patients. Creating public awareness appears simple, but I can tell you it is the most difficult thing, interacting with the public. I think if all members of the professional bodies start interacting with the public and creating awareness, a lot can be done for the lung health, I can assure you. We require unified approach. If we are talking about the collaborative efforts, we require unified approach. Unified approach means if the guidelines are made, guidelines are accepted, then we have to ensure those guidelines are followed by every doctor, whosoever is treating the patients. But this is not happening. Each one of us is writing his own prescription. And that's not a unified approach. Unified approach should be when we join hands with other professional bodies and can have an impact on the policy of the government for the benefit of the patient, for beneficial of the country. Similarly, knowledge exchange, of course, we do with the conferences, with the international conferences, international people are coming. But then the guidelines which are there, which are relevant to the other developed countries may not be relevant to us. My suggestion obviously is that Indian Medical Association must make its own guidelines on different areas, and it should be accepted by the government. At this moment, it's the government which makes you accept the guidelines. I know I am a member. I know Professor Ashokan have been sitting with us many times making guidelines, or some of you from when we made the guidelines for how to involve the private sector in tuberculosis. I know many of you were sitting with us, but factually, it is the government guidelines, and we show that we have taken the help of the government. It's not the guidelines meant for the general people, general public, and by doctors, benefit of the doctors as well benefit of the patients. Lot requires to be done as for collaborative efforts for the lung health are concerned. Research, education, advocacy, and patient care. Advocacy, I put it here, where unified approach is very, very important. Where there you have to find the ways and means to involve other professional bodies, take them under your umbrella as an IMA, and help to make guidelines not only for COPD or asthma. Today we are talking lung health, but hypertension, like diabetes. These are the comorbidities which are also affecting and leading to the high mortality as far as our country is concerned. Look at the impact that these guidelines, if followed properly in the developing countries, their mortality reduction has been almost to the tune of 40%. Smoking cessation have been achieved in many countries to the tune of almost 75%. And the increasing and becoming providing affordable drugs, providing affordable therapy, providing treatment services to the patients has improved their life almost in more than 60% of the cases. For example, asthma, it is choice is inhalers and not simple drugs. Therefore, providing affordable medicine to the patients, to the public, is the responsibility of the professional bodies by creating the change in the policy, having an impact on the policy, and thereby ensuring that general public not only is made aware, but they are empowered of the treatment not only treatment, but a correct treatment for their benefit so that we can reduce disability adjusted life years. And let us see if these can be retrieved so many years. Well, ladies and gentlemen, it's my final slide, and I feel it's a call of action to the professional bodies that you support different organizations. You should champion the vital work of professional bodies. You are the leader. You have to take the lead. Make advocacy for a change. Join initiatives for promoting clean air policies, tobacco control measures, and increase healthcare access to your community. That's what last point I was talking about. Invest in the future. Funds, from where the funds can come. If the government's funds, we can create an impact to get the funds to be allocated at this moment in a different situation which affects the large population. The future of lung health depends on our collective commitment in supporting these essential organizations, and together we can build a world where everyone has access to clean air and excellent respiratory care. With this message, ladies and gentlemen, I think lung health is our life. Let us save it. Let us be together to ensure that we together can achieve this. Thank you very much, ladies and gentlemen. Professor Sarma?
Sharma,
Sir, I need.
come back online. We should thank him
Yeah,
for
yeah.
this excellent
Okay,
lecture
okay.
and
No,
leadership. Yeah, go ahead.
okay, so now I got it. So thank you, Dr. Arora, sir, for the wonderful input regarding the role of the professional bodies. I mean, with all your experience and expertise, you have rightly pointed out the about the preventable disease of lungs and also the key reasons for the lung health, ill health, and also the importance of overweight and its reduction. And we also highlighted the climate change and also the NCDs and the how to control, what are the control strategies to control the lung diseases. And also you have rightly pointed out about first the Forum of International Respiratory Societies, which has rather initiated this World Lung Day. So thanking you very much. And also, I mean, at this point of time, as already Alora pointed out, I wish to bring to the notice of the audience that we had an MOU with the TAB Association of India, and the action against stigma was taken up at all India level, and many state branches and local branches have organized a very good number of programs against stigma. So in conclusion, let me share my screen. 1 second. And now, as we have seen, there are many important days given by WHO regarding lung health. All of you know that World TB Day, and on World TB Day also we have done a good number of programs all over the state, all over India also. And World, that's on 24th March, World Asthma Day 6th May, World No Tobacco Day 31st May, World Bronchiectasis Day 1st July, World Lung Cancer Day 1st August, World Lung Day 25th September, that is today, World Pneumonia Day 12th November, World COPD Day 19th November, and World AIDS Day 1st December. So these are all the awareness days which are to be observed by the professional bodies, as rightly informed by and structured by Dr. Arora. And IMA and all other professional bodies like other, including the societies, TB association and all, they need to rather educate the public regarding the lung health and on the respective days. And so we have understood the importance of lung health for a healthy life by both the speakers. And we know the common lung health awareness days and plan suitable events to the IMA and other bodies. And at this point of time, we need to coordinate with other sister professional bodies. And also we need to represent to the government the need for more involvement of the private sector in all health-related programs. Because till the other day, actually, right, Ashokan is very much here, and we had a good program all over India regarding the RNTCP and also the TB notification, etc., etc. So, but unfortunately, now the private sector is not fully involved. So, there is a very much need to involvement of the private sector in all the health-related programs, especially the TB control and also the lung health programs. And we need to, from our side, we need to sensitize and train our members, IMA members, paramedicals also, regarding the quality of care and also the various ways of involvement of others people in healthcare delivery. And action against stigma, that is already been focused on, and patient is to confidential. Definitely, we need to rather assure our patients the confidentiality, let it be a TB, let it be HIV or whatever it is. So these are all the been rather my humble rather wrap up, and we need to work hard together for a healthier life and with a good lung health. And now Dr. Srilata has raised her hand. When if she is available, she is requested to give permission. The organizers can request her to unmute herself, and then the only one hand raise was there. We'll quickly, if she is available, it's okay. Otherwise, we'll forget about it. Dr. Srilata, are you there? So there is no response. So let us this thing. And now, so we have come to the end of the program. Yes, Dr. Sri Lakshmi, there is a hand raising there. I think headquarter can look to that. Hello. Hello.
So she is unmuted, sir.
She is not ready.
He wanted the earlier slide.
Okay. So then now we'll go, we have come to the end of the program, and now it is my pleasure and the pleasure to invite Dr. Shiv Joshi, of the convener of the standing committee, to propose vote of thanks. Over to Dr. Shiv Joshi.
Thank you, Sarma sir. As we come towards the conclusion of this World Lung Day special webinar, I want to express my heartfelt gratitude to our esteemed speakers, Dr. Upasana Agarwal, madam, who told us about the personality and attributes of the captain of Man of Death in India, the tuberculosis. Dr. V.K. Arora, sir, for highlighting the role of professional bodies in this fight to end TB. I want to thank our dear Dr. P.S. Sarma, sir, who is also the co-chairman of the IMA TB initiative and the moderator, for being the glue that bonded us together during this engaging and very important webinar. I want to express my admiration for Dr. R.V. Ashokan, sir, our very dear chairman of the IMA and TB initiative, for being the guiding force and an intellectual and strategic leader to show us the way forward. I extend my thanks to the IMA headquarters with Dr. Dilip Bhanushali, sir, our national president, Dr. Anil Nayak, sir, our national president-elect, Dr. Sarbai Datta, madam, Honorable Secretary General, Dr. Piyush Jain, sir, Honorable Finance Secretary, under the overall vision of our chief patron, Dr. Ketan Desai, sir. I want to thank my very own family in the profession, IMA JDN, led by Dr. Shrijitan Kumar, sir, who is also the national chairman, and Indranil Deshmukh and his entire team of IMA JDN for coordinating this session with junior doctors. And of course, last but not the least, a dear audience who I'm very sure must have benefited from this very important discussions that were conducted today. Thank you, everyone, for joining this important webinar.
Dr. Sri Lakshmi, thank you, Shiva. Sri Lakshmi.
No, just 1 minute. Indranil.
Yes, sir.
If there is a clarification you would like to provide to the people, and if there is any complaint, let them put it up in the WhatsApp. Let us see what could be done about it.
Yeah, sir. I have already shared my WhatsApp number in the chat box. They can message me. And sir, we have already shared 2 registration links. One is for today's session, for today's session, e-certificate will be given within 3 working days. And a second link is for the upcoming free pass to the 2 credit point online CME, which JDN is only conducting on 26th September, that is tomorrow at 4:30 p.m. And same things has been conveyed previously in the WhatsApp group as well. And for any query, you can kindly message me. Thank you very much.
Right, Indranil. Sharma, you can close it.
Yes, sir. So, pranam to everybody. Thank you very much. Thank you. Thank you. Bye, bye, bye.